Hello, and thank you for joining us for a heart failure hour. My name is Rayan Yousefzai. I'm one of the advanced heart failure and transplant cardiologists. We are very excited to have a truly an expert panel joining us from all around the world. We have Dr. Peter Liu from Canada. Dr. Liu is a Chief Scientific Officer and Vice President of Research at the University of Ottawa Heart Institute, and joining us from Canada. Dr. Guillermo Torre, he's a Professor of Cardiology. He's from Houston Methodist, joining us from Monterrey, Mexico. And in the studio with us, we have Dr. Barry Trachtenberg. He's a Director of our Cardio-Oncology and Amyloidosis Program and Program Director of Advanced Heart Failure Fellowship. Thank you, everyone, for joining us.
Thanks, Ryan. So just a couple of housekeeping items. We definitely want this to be interactive, and so if you have questions, we will get to them along the way. There's two ways to get your questions. One is to go to the web and go to pollev.com, enter DEBAKEY, and then respond. Or you can text DEBAKEY to 37607 and then text your message. We're very thrilled to have Dr. Liu and Dr. Torre joining us today.
Thank you. We're gonna keep this interactive and with a discussion. So I start with the case here. This is one of our patients, 54-year-old woman with past medical history of hypertension, who presents her off-site hospital after 3 days of shortness of breath, chest congestion, and cough. On the presentation, the vitals were respiratory rate was 26, heart rate 126, blood pressure 111/69. She did not have any fever. And her troponin was elevated at 68. Based on that, she ended up having echocardiogram. As you saw, this is the TEE, and we see severely LV dysfunction with a global hypokinesia. So, and a few hours later, her blood gas showed severe acidosis with the elevated PCO2. She was intubated, and after the intubation, she became very hypotensive, was started on norepinephrine and epinephrine. She was taken to a cath lab. Here are hemodynamics on the cath lab. The RA was 10, pulmonary artery pressure was 49/32, mean of 38. Pulmonary capillary wedge pressure was 30, and severely reduced cardiac index of 1.5 on inotrope. Also, she had a left heart catheterization which showed normal coronaries. Based on these findings, the Impella CP was placed, and she was transferred to our hospital for further management. On Impella CP and epinephrine of 5 and norepinephrine of 10, she was still not very stable and with elevated lactate of 8. So I will just stop here, and I will ask Dr. Trachtenberg to kind of give us what he thinks about this patient, what are your differential, and how you would continue managing this patient.
Yeah, I mean, this is certainly a very sick patient who looks like has an acute cardiomyopathy. The left ventricle is severely hypokinetic and not dilated. So this seems like an acute process as opposed to an acute on chronic process. Of course, here we're talking about inflammatory cardiomyopathies, and she has normal coronaries, so myocarditis is the top of our differential, as it would be for someone that comes in with this presentation. That's so acute. So she would be someone that we'd say is in fulminant myocarditis. So she's on a CP Impella with 2 fairly high doses of inotrope and vasopressor support. So I would see, one, are those doses just there because they were trying to keep those doses while she was being transferred? If I'm going to see if I'm able to wean those quickly. If not, then I'm going to be worried about having to give her more support, perhaps biventricular support, and a low threshold for VA ECMO if that lactate's not getting better and if I'm not able to wean down any pressors. Any other thoughts from the panel? Dr. Liu, Dr. Torre, I don't think we've seen you guys yet. Okay, welcome.
Yeah, so thank you very much. Yeah, so with a patient like this, one's very, very worried, because obviously the prognosis is much worse when the patient is having so much hemodynamic compromise. And so excellent support is absolutely critical. And then the question is, could one actually make the diagnosis, in her situation? And I think those considerations, and you folks are obviously a super expert at this.
Barry, I think I'd like to make a comment for the audience, and of course we're talking about today myocarditis and inflammatory myopathies, but de novo heart failure on a 50-year-old patient, whether it's a male or a woman, I think one has to discard the possibility of having coronary artery disease because that's a treatable condition. And I know we are today discussing inflammatory myopathies, and our discussion will follow into that. But it is important to remember that we must be absolutely certain that we rule out coronary artery disease. Positive troponins in a 50-year-old female patient, I think it is imperative that we discard that because a specific intervention may lead to a beneficial outcome. So having said that, I think in this case, the only other thing that I would put into the equation is, yes, you have to support it, and that is important. Maybe you consider more advanced mechanical support strategies. But someone who has profound heart failure in the context of normal coronary arteries with this accelerated course, we must try to understand what is the inflammatory condition, because we haven't seen arrhythmias that if you have progressive heart failure to this point, then maybe arrhythmias, the possibility of giant cell myocarditis that require a specific intervention or a specific anti-inflammatory strategy will be beneficial. So I think I would leave my comments to that as of for now.
Thank you, and that's great. So I think that this patient, as you mentioned, very still hemodynamically not well supported, as elevated lactate, so the biventricular support will be really beneficial. So we decided to put the patient on the VA ECMO to support her at this point. And as far as the other management, as everybody mentioned at the panel, there's a suspicion for myocarditis, and inflammation is very high in this young patient with no coronary artery disease. So she ended up getting 3 doses of high dose of soluble Medrol 1 gram. She went for an endomyocardial biopsy, which showed diffuse lymphocytic myocarditis, and these are the true slides from the patient, the actual patient. The viral PCR was sent, and it was negative, and she was given IVIG empirically for treatment, and started on the steroid taper. Any comment from the panel regarding the treatment choice and anything you would do differently? Dr.
Yes. Yeah, so absolutely. So, even though the myocarditis trial, for example, was negative in terms of using steroids, but that's in a more subacute setting, in patients who was actually very acute. Certainly, one would be very much thinking of how to attenuate the excessive amount of inflammation. And but I would say that the fact that one do actually see quite a bit of inflammation, and with acute presentation and the less dilated heart, gives me some optimism, because in this type of setting, it suggests that this acute inflammation accounted for a lot of the cardiac suppression, and that if there is actually ultimately dissipation of the inflammatory changes, patient can actually recover. So this is the hope that we would have for this patient, as long as the patient's able to be adequately supported in the meantime. And then, one may escalate the level of immunosuppression. It really actually depends on her response is. And but I think it's very good that the one actually do have the biopsy confirmation, because the disease sometimes is patchy, and so one may not always be able to capture the inflammatory foci. But in this case, I think certainly one has the still we call the gold standard of diagnosis, and that's the inflammatory and the cell death on biopsy.
Ryan and Barry, I think I would agree with Peter's comment, and maybe also emphasize that the diagnostic information of the biopsy allows, in this case, to prognosticate some. And the importance is that this patient doesn't have giant cell myocarditis, that the prognosis will be totally different. And even though we have a patient in profound shock requiring biventricular mechanical support, the probability of improvement is still significant, despite the fact that at this moment is critically ill. So if you support the patient, the overall prognosis may be quite good. And if we want to give numbers, I think I can quote the myocarditis trial with IVIG the IMAC trial that Dennis McNamara led a few years ago that showed that about a third of the patients will improve regardless of what the initial ventricular function is. Another third may remain without heart failure, but improve clinically, even though the EF has not improved, and only maybe a third will remain in very poor function. But what we're saying is that about 70% of these people will improve, regardless of how they presented. So this is important information for the patient, for the family, for the doctors to consider, and be very aggressive in supporting, even to the point that you're having to place them on mechanical support. Now, if this was giant cell myocarditis, at this moment, we would be considering the possibility of transplantation, long-term mechanical support, which is a totally different situation. So I think that the fact that you establish a clear diagnostic of lymphocytic myocarditis is quite useful for management, for information, and for prognosis to the doctors and also to the patient and the family.
Yeah. And I think we're going to talk about giant cell also a little bit later, but I think it's really important, as you guys both mentioned, that when we talk about immunosuppression, there's some data for chronic myocarditis, and we'll get into that. But for acute myocarditis, there's really no, for lymphocytic myocarditis, there's no prospective data, no randomized data. There is some retrospective data that indicates it might not be efficacious, but there's never been a really good randomized controlled trial for fulminant myocarditis. Now, if this were giant cell myocarditis, it would be indicated, but just the solumental by itself wouldn't be sufficient. So we're always, when we see someone like this, we want to do something, and sometimes doing something, may help or may make us feel better. I don't know which, but I think the most important thing is getting the biopsy while you're either doing or not doing that, so you can have the data to know how you should be optimally treating these patients.
Yeah. I also want to
I guess, Barry, let me just make a comment. Whether we use steroids or IVIG, just an extension of your comment, I don't know if it treats the underlying condition, treats the doctor, or what does it treat, because we don't really have evidence. I don't argue against the use, and in fact, I have a bias for IVIG, maybe because we participated with Dennis in the IMAC trial, but I don't really know if it works or not. I think that the fact of the matter is that we do it as of a presumptive mechanistic explanation for the mechanism of LV dysfunction, but it's been really very hard to prove that what we do has a demonstrable effect in the outcome. But so I just kind of wanted to establish that point.
Thank you. I also want to raise this question as far as the viral PCR. It always comes the question to sending a viral PCR, how important it is, and would that affect your management, viral PCR being negative versus positive for this patient?
Yeah, so I absolutely agree. So if one actually meticulously do viral PCR and then do the whole viral panel, one can pick up quite a bit of viral positivity, and common viruses, being common, and but the question is, whether that actually affects the clinical management. A lot of time one would pick up, for example, parvovirus, which may or may not be pathogenic in that case. And the early days, obviously, there was enterovirus, but they tend to be seasonal. Right now, of course, there's a lot of concern regarding COVID, even though COVID may not actually cause myocarditis per se. Certainly not in pictures like this. So I think most people would do this as a kind of a part of a due diligence, and but in terms of the treatment, it is not as much influenced because currently we don't necessarily use antivirals. However, certainly the Europeans are more meticulous at this, in that if they do find very high viral load, they may shy away from giving steroids or immunosuppressive very aggressively in the beginning, just to avoid the virus being unchecked in terms of immune system. But in a more chronic setting, they would actually then use immunosuppressive. So I think it's still, an evolving area.
Thank you. So our patient was, this is the echo a week after. So with the immunosuppression, was very nicely recovery, and we were able to decannulate the ECMO, and patient did really well and was discharged and went home after. So she responded nicely to the immunosuppression.
So
Ryan,
yeah, or the ECMO. I mean, so it's hard to
That's right.
Yeah.
hard to know. But she did great,
Well,
and was able to be decannulated. And as Dr. Torre said, some of these patients have great spontaneous recovery. We don't know how much the ECMO came into play, just supporting her to let her do that, versus the immunosuppression, or both. But this is that great debate we have. If you're the guy that gave the steroids, it's the steroids.
Sure.
Yeah.
Well, the family will be very grateful, to Ryan and the Barry anyway. So take the credit.
No. I think I of course take the credit, but I think the question is, to what extent the mechanism of unloading also has a healing capacity in addition just to support versus the anti-inflammatory effect. I am totally convinced, and I will tell you an anecdotal story, that the distress that caused by the pressure overload of volume overload in the myocardium perpetuates injury. So I think that the mechanical intervention has a healing effect. I mean, of course, it's my bias, right? But it's as much as the bias as the anti-inflammatory strategy, that I think the therapeutic intervention of mechanical unloading is in addition to, and it's not only keep the patient alive. I think that when you take out the stress of pressure or volume overload, the myocardial fiber is alive, and it's not getting progressively killed by stress, by hypoxia, by the stress-mediated injury that occurs. So I think that what is going to be the actual protocol for treatment of these people over time? Well, it's imperative on us to try to prove as hard to come by. We haven't been able to do them in 20 years or 25 years. But I think mechanical unloading has a role, and I would now say that we have tools that are very accessible, that are percutaneous, that are safer and effective. I favor, and I think I applaud the fact that this patient underwent aggressive mechanical intervention, because I think it does provide not only support to keep the patient alive, it aids the healing process. And I would argue, Ryan, that is even of more value than the anti-inflammatory strategy. We haven't been able to prove. Maybe it has a role, but I think the natural anti-inflammatory milieu of the host, or the viral anti-inflammatory response that occur, it's of great value. But what the body cannot do is relieve the heart from the pressure and the volume overload stress. So I think that's a very important intervention.
Thank you. And as far as kind of talking about this inflammatory and myocarditis, we think about the etiology and what's causing it, that there are really three major categories. One is the autoimmune disease. These are patients with the connective tissue, the giant cell, sarcoidosis, eosinophilic, could be direct toxin effect or infection, most common being viral. However, shouldn't forget about the bacterial and fungal and protozoa infection as well. The pathophysiology is, and I would like to comment from the panel here, it's somehow understood. I think in the viral myocarditis, there's three phases that has been identified: the acute phase, the entry of the virus, the replication and direct toxicity of the virus to the myocardium, and eventually activating the patient's immune system that's causing more acute, that happens in a few days, and more in the subacute, which happens in a few weeks to a month. That's more activation of the T cell and cytokine activation, which kind of leads to the chronic phase of more causing the heart failure and scarring of myocardium for this patient. And I want to kind of ask the panel, and maybe start with Dr. Liu, to shed some light on the pathophysiology in the virus versus non-viral myocarditis.
Yeah, you summed really well there, and so we usually think of the virus as a trigger, but I would say that the virus may be an incidental passenger in the susceptible individual, and it's really the immune response that makes the difference. It's very similar to what we see with COVID, right? Same virus, yet the the response, in the host is hugely diverse. And so it's really actually the immune response that we see, and this is usually the stage actually we see the patient, because the viral phase quite often is gone by the time they present in the ER. And I think then it's really actually in terms of the degree of balance of the immune that's a pro-inflammatory, that's potentially destructive, versus, as the process goes on, as Dr. Or Guillermo mentioned earlier, that in fact the natural anti-inflammatory process comes in and then rebalances the situation. The more important thing down the road, of course, for this patient is what is the natural history for this patient, and as Guillermo mentioned earlier, whether the patient is going to actually fully recover or in fact will be burdened with a cardiac dysfunction.
Thank you. As far as the presentation of this patient, they can present with chest pain, which is usually they have the best clinical outcome, or they can come with the acute cardiomyopathy, heart failure, outcome is worse, or with the sudden cardiac death or VT, which has the worst outcome. So talking about the diagnostic of this patient, we have most of our tool that we use in a regular daily basis, meaning EKG, echo, they are very non-specific. And even though there are some studies has shown prolonged QRS or Q waves or left bundle branch block associated with the worst outcome. MRI is the most frequently used diagnostic for myocarditis, and with their newer techniques, the T2 weighted mapping, the T1 and lead gadolinium enhancement being the cornerstone of using the in the cardiac MRI. So I want to bring up, to maybe start with Dr. Torre, that when do you think about ordering MRI? How do you use the MRI for this patient, and how do you use the MRI for a follow-up? And if you use it anything for a prognostication for this patient?
No, I think MRI has given us an opportunity that we didn't have in the past. You should think of MRI as an imaging, a window to the histology of the injured myocardium. And I think that without any question, the availability of MRI has expanded the precise diagnosis of individuals that have the syndrome potentially associated with myocarditis. So I think Peter may comment on this a little later, but with the clinical findings, with the associated features in an MRI, the need of the biopsy is actually secondary, and it may be for research purposes for the assessment of viral presence by PCR, but not necessarily to establish the diagnosis of the inflammatory associated myocardial dysfunction. I think that it provides with an opportunity of define the entity, and then of course it allows you to prognosticate based on the severity of the injury, the size of the myocardium. People have looked also strain, whether or not there is already the presence of fibrosis or not. And all these features may be somewhat evolving, and how at the beginning you can establish all these abnormalities and the potential prognosis. I think that there are a number of papers that suggest that 1 or 2 or 3 different features may allow you to prognosticate. So I think that it is unquestionably a tool that's of great value, of course not accessible everywhere, and of course, and maybe of course in the US we have more availability, but in Canada it's a little more limited, certainly in places like Mexico or South America. So we cannot make a statement that everybody what we suspect we are going to have the opportunity to do an MRI. And in general, in a case where you don't have associated features of a complicated condition, it may be academic, it doesn't have necessarily, it's not obligatory to do it. You can certainly establish more cases that demonstrate inflammation if you do a lot of people, but whether you have to do it in individuals that present with chest pain where you don't have access, I'm not sure that you necessarily have to refer them to a place unless you want to do research or want to pursue, but I would certainly reserve it for those that have high-risk features, people with arrhythmias, people with depressed ejection fraction, with clinical symptomatic heart failure, with a progressive course, and those need to be referred. And when you refer, you need to do an MRI. If you have a non-complicated case of a young individual who have chest discomfort that has predominantly pericarditis symptoms with EKG-associated changes, and there is no associated worrisome condition of very high troponins, heart failure symptoms, you probably don't have to. You may want to do it, but if you don't have access, you can live without that information. So I think that those will be my recommendations, so that we don't stress the audience and say, oh, everybody has to have an MRI. It's nice if you have it, but it is not obligatory. But in those that have high-risk features or have heart failure symptoms, severity of arrhythmias, extraordinary high biomarkers of risk, I think you may want to refer, and in case, do an MRI that will help you to prognosticate and then follow the clinical course of the condition. Peter?
Yeah, I fully agree. You do a test because you want to answer the question or make the proper diagnosis. And so, MRI is particularly good, in patient, what I call kind of a subacute setting, which is establishing diagnosis is helpful, in which you establish that the patient either has ventricular dysfunction and arrhythmias, and then knowing whether this is myocarditis or something else is helpful. So that's where MRI is helpful. But we talked about earlier, when the patient's super sick and, hemodynamically unstable, hard to get an MRI in that setting, and that's where the biopsy, will be important, because you can make a clinical decision based on that as well. Yeah, so fully agree.
So
and Ryan, let me just make an additional comment, Ryan O'Brien, because I just saw a case 2 days ago of a 40-year-old young male who's active, but smoker, hyperlipidemia, family history of heart disease, and has very typical features of pericarditis. But the EKG is worrisome. I don't think that you need to bias immediately say he has myocarditis. I think it is more important to rule out coronary artery disease as the mechanism. Even the clinical feature is more suggestive, because if you miss coronary artery disease, then you're going to cause these men a great disservice. So I think it's important to keep that in mind, that when you have someone with a high probability of coronary artery disease, it is imperative to rule out coronary artery disease. And I think not to be just biased. And I think that is important. I think we can, we have a lot of features that may say, well, this is most likely pericarditis, but I think today you do a CT angio and you rule out the diagnosis in 15 minutes, right? You don't really need to do a lot more. And then you can decide what to pursue for the diagnosis of myocarditis.
Yeah, and I just want to make one comment on MRI before we kind of wrap up that discussion. And Guillermo, to be honest, I thought we'd be debating whether or not everyone should get a biopsy and not about MRI, whether everyone should have an MRI. So I think it's important when we talk about MRI. I think it's become a great tool to aid in the diagnosis and also to aid in research. But I think, much like we had a grand rounds today where we talked about HFpEF and better phenotyping, and that not all HFpEF is the same, and we need to do a better job of really getting into the weeds of what the diagnosis is. MRI is more of a generic myocarditis diagnosis, and so unless if the patient's really stable with a borderline normal EF, I think it's fine, rely on MRI. We're going to just treat them with GDMT no matter what. But I think for patients that are a little bit sicker, then I think we definitely need to do a better job of not relying on the MRI for our diagnosis, because it could be sarcoidosis, it could be viral myocarditis, it could be, of course, giant cell and a host of other different etiologies. So I think it's really important that MRI is a really great tool, but I think sometimes we over-rely on it to make assumptions.
Sure. No, Barry, I don't disagree with that. And as you and I know, you guys do biopsies every day, and the complication rate is near zero. And I think that's okay. So when you have the availability of a good lab, when you can do molecular testing, and you know how to do safely a biopsy, I think you're fine. But I think for the public at large, and when you're not in a tertiary care center, biopsies are big, high, complex interventions, because the doctors are not used to do them, because the pathologist doesn't know how to read them, because they do very little cardiopathology, and I don't think they'll have access to do the molecular analysis. So yes, I think places like us, we should develop protocols to try to advance the field. But in general, for the community, the routine use of myocardial biopsy is probably not the same as we would do in a place like where Peter or at Methodist. It's a different story. Ottawa, big places in Canada, big places in the US, but it wouldn't be applicable to the large number of community places or smaller hospitals in the US where people take care of this condition.
Absolutely.
Yeah, I think I just kind of this a nice segue to the next question. I'll ask Dr. Liu. That's the biopsy. You know, we, as Dr. Torre mentioned, you know, we like our center, we do biopsy. You know, the myocarditis. Want to diagnose them a type of, especially, we don't want to miss the giant cell myocarditis, which the treatment can be very different, as Dr. Torre mentioned. So, Dr. Liu, what makes you think, and when would you do a biopsy on a patient that comes to you with the suspicion of myocarditis, and how is that change your management, before getting a result or while waiting for a result for getting for a myocardial biopsy?
Yeah, it very much follows what we discussed earlier. You know, for example, the patient's coming in quite acutely sick, and you wondered whether patient is going to ultimately be a transplant candidate. You know, and that's the situation. You need to have a diagnosis. You need to find out, whether this is a potentially an inflammatory process, or in fact, patient has, burned out cardiomyopathy. And then, of course, the patient has arrhythmias, and that makes you suspicious of a giant cell or other conditions. It could actually be a sarcoid, right? And then in which you get a lot of arrhythmias and heart block as well. And so I think making those diagnoses and therefore can help you to establish a treatment plan would very much warrant a biopsy. And I should mention that the no question biopsy has not changed very much in terms of its tools, but there are now new biopsies that actually can be done potentially very easily by percutaneously, and of course better imaging guided strategies can actually make this both higher yield and also safer. And so I think there may be some evolution on the biopsy, but I absolutely agree that currently the biopsy is not really a very, very user-friendly procedure, except in highly trained centers.
Yeah. And when we do the biopsy, Dr. Torre mentioned about molecular testing. Barry, I just want to ask your opinion. Where are we with this molecular testing? When do you send it, and what are the future of this molecular testing for it?
Yeah, no, it's a great question. So, the concept behind molecular testing and is if you can, starting with the biopsy in cardiac tissue, is if you can do genomics or gene expression and have a signal for myocarditis. And Josh Hare, who was helped train me at University of Miami, he published this. Bettina Heidecker and Josh published this data, I think approximately 10 years ago now, showing that you can take a biopsy sample from patients and you can distinguish myocarditis from non-myocarditis just by one sample using gene expression data. Now, so that was, it's been 10 years working on trying to replicate that, and some other groups have been in that space as well. And eventually the hope is that not only can they replicate that, but then if you can correlate that with serum gene expression biomarkers, that you would be able to find something in the blood. Now, we're not there yet. This is hard. It really needs to be a multi-institutional trial. The technologies change every few years in terms of gene expression. So I'm hoping that we'll have data in that space in the next few years. But for right now, research is out there, but it's not yet ready for clinical use.
Thank you. And Dr. Torre, I'll bring this question to you. You mentioned, in other places there, not the tertiary centers, that maybe you cannot do MRI, maybe you don't have the biopsy. What are the role for biomarkers, inflammatory markers? How do you use it? And if it's going to make any changes of your management for this patient?
Oh, you're muted. Yes.
Oh, sorry. I was trying to be diligent and not to bias the conversation. But I think that if you have a patient that has de novo heart failure, LV dysfunction symptoms, you don't have you rule out the diagnosis of coronary artery disease, and you define this as acute onset cardiomyopathy, and you rule out the common conditions that are infiltrative conditions like amyloid sarcoidosis, for instance. The positive biomarkers will strongly support the idea of myocardial inflammation, of course, in the context of the history. And I think it seems reasonable in that setting that you establish the diagnosis. And this is the principle why many years ago, the protocol that I discussed earlier, the IMAC trial, which was an intervention in myocarditis and acute cardiomyopathy, we kind of lumped those two conditions together. Because from a very prognostic standpoint, if you rule out amyloid, sarcoid as the most common inflammatory, non-typical myocarditis conditions, then you can probably have a relatively simple course of the illness or similar common course of the illness. So I think that you can establish that diagnosis with positive biomarkers, the clinical scenario, and ruling out coronary disease. And I really cannot emphasize that more because, yes, we're discussing today inflammatory conditions, but the fact of the matter is that the common presentation of heart failure is more likely associated with coronary artery disease. And I think that's really important to establish. So positive biomarkers in the clinical setting, when you rule out coronary artery disease and you rule out amyloidosis and sarcoidosis, I think it really points to that condition. And I would be happy with that if I don't have access. And if the course is benign, I would leave it like that. If the patient gets sick, I think if you're in a place that is not familiar with biopsy, that doesn't have an MRI, you should refer to a tertiary care center. Refer to Ottawa, refer to Methodist, refer to high tertiary level care academic medical centers. I think that's what you should do.
Thank you. And that's kind of bring me to the next kind of topic I want to bring, the fulminant versus non-fulminant. As far as the presentation, which, fulminant as patient presents with a more cardiogenic shock type of picture, like of a patient did. The reason I bring up this topic, that some of the data has been discrepancy between data. Earlier trials, this is the trial from 2000 that identified fulminant versus non-fulminant, which was diagnosed by biopsy. The patient who had a fulminant, they did better actually than the patient who presented with acute myocarditis. There's now a number of the death and transplantation. However, the later on data, which is the diagnosis mostly based on clinical imaging and myocardial biopsy and identifying a patient fulminant versus non-fulminant, the prognosis was different. The patient with the fulminant is worse than people with the non-fulminant as far as the survival, as far as the EF, starting with the lower and staying low EF. And obviously the patient with the fulminant had a higher percentage of going under the treatment and immunosuppression versus patient with a non-fulminant. And this is kind of the most recent finding in 2019. These are actually patients who were more acute. There was a discussion that this patient, the entry time was different. Maybe the myocarditis was resolved by the time they entered the study. This study was more an acute within 30 days, low EF, and kind of shows the same type of pattern that patient with fulminant presentation, they do worse as far as the survival and cardiac death and transplantation. So I just want to open the discussion here. That's the fulminant. Obviously, we need a mechanical circulatory support if the patients need an inotrope pressor or mechanical circulatory support for circulatory wise. But how that would affect your management for the immunosuppression therapy, and how will you choose between fulminant and non-fulminant myocarditis? Maybe I'll start with Barry.
Yeah, so I think the data is, for me, the way I interpret the data, and again, for going back to fulminant, no really randomized trials except for in the setting of giant cell myocarditis. So I think if you have, giant cell myocarditis, clear indication, they'll benefit from steroids plus OKT3 or cyclosporine or something else in addition to just the steroids. But there's definitely for non-fulminant, there's no clear data at all for immunosuppression except one study that looked at patients 6 months out, chronic, viral negative. And then a small study showed that they benefited from prednisone and azathioprine, and there's supposed to be a follow-up study to that, which is not yet out. But in terms of fulminant, if they have sarcoid or if they have giant cell, clearly benefit from immunosuppression. Otherwise, there's no clear benefit. So that's why I think it's really important to get the tissue and get the histology. And I think if you show the next slide, you'll see that that you can see on the right panel, the mortality for the patients with giant cell, which is in the blue, is much worse than the eosinophilic or lymphocytic myocarditis patients.
Any comment from Dr. Liu or Dr. Torre for the?
Yeah, so I think certainly, the Hopkins study was the classic, but, people probably missed the fact that, in fact, there were only, sort of a little over a dozen patients, with the fulminant myocarditis. In fact, those who are actually from Hopkins were only 4 patients. The others survived the transfer. So, so it's a highly selective population. And so it becomes a little bit of a legend. From in the field, and I think the more recent study is much more reflective of the real world setting, and exactly as we kind of all mentioned it with your case, that patient certainly with this type of situation, the prognosis is much worse, and obviously warrants the full hemodynamic support, full diagnosis, and then sort of deciding on what the natural history is for that patient. Very fortunate the patient was able to recover at least the ventricular function, but I think long-term follow-up is still very, very important, as indicated by the natural history studies.
Yeah, I think that's a good point. I think also it's important to highlight that fulminates, those that survive, a lot of them make a complete recovery, a rapid onset, and then they're able to make a full recovery with resolution of inflammation. But certainly, there's clearly data now that we have from this circulation paper that they clearly have a worse prognosis. But you can see that if we show this slide here, that if you look at data, this is just kind of a meta-analysis of patients with fulminant myocarditis on ECMO. If you pull that data, the survival to discharge is about 64%, even if they are so fulminant that they need ECMO. So I mean, obviously that's not you'd want that to be higher, but that's pretty good for ECMO population that comes in with fulminant myocarditis. So that's somewhat encouraging, but clearly fulminants, I think the legend, as Dr. Liu said, that fulminants do better is partly based on that small trial, but partly based on the fact that those that do recover tend to make a very good recovery.
Thank you. And we touched on the treatment multiple times, and as Dr. Torre, Dr. Liu, and Barry mentioned, some of the trials have been kind of disappointing. Earlier trial, there really hasn't shown that much benefit, either immunosuppression versus IVIG, and come across this trial that they looked at patient responder versus non-responders, and patient who they were negative for virus and they had the autoantibodies, cardiac autoantibody, they responded much better than the other patient. So that kind of brings the question that with all the trials and the clinical management, are we treating the right patients, or we need to do more investigation to kind of tailor our management to these patients? I'll just bring up maybe Dr. Torre can give us a comment on that.
Yeah, no, I think that there is no question that better profiling will identify a group that may improve better. And I think that the question is, what is that profile that is more likely to be responsive to a particular type of therapy? And when we talk about myocarditis, the question is, do we want to treat the virus? If we think the virus is the causal agent, do we want to treat the inflammatory response? If we treat the inflammatory response and the virus is still active, if you suppress inflammation, the virus may blossom and then you'll cause injury. So I think to define virus and inflammation has set an initial path for identifying phenotypes. And I think that's important. Now, until now, with the exception of the group in Germany, maybe a little bit in Italy, we really have not been able to define that further and then to establish the significant prospective trials that conclusively answer that question. So I think, but that is something that we ought to do over time. The balance between virus and inflammation as the mechanism responsible for cardiac dysfunction. Now, and then when we talk about inflammation, you can talk about the molecules that are responsible for inflammation, and then you can define even further. So today we say, well, either we treat with an antiviral agent, we treat with anti-inflammatory strategies, and I think that's where we have difficulties in deciding what to do. One of our colleagues that Barry and Peter know very well, Carson Chope, gets very biased to the importance of the virus, and he gets very concerned. And his group has established guidelines to treat with antiviral agents versus anti-inflammatory strategies. So I think that further into the near future, we have to develop an organized task force to define those questions that today have biases, but not conclusive randomized data. And I probably would just leave it like that. But do I believe that better phenotyping would lead to better therapy? No question. But in general, that principle applies to everything we do in medicine. Coronary disease, HFrEF, HFpEF, improve EF. So I think we have all of these scenarios where better phenotyping would define the population a better chance of improvement.
Okay, thanks. I just want to, have this opportunity to bring it up before we run out of time. I want to, there are a lot of questions, a lot of controversies in the field. We have experts. I don't want to lose this opportunity to ask Dr. Liu, Dr. Torre, and Dr. Trachtenberg, what are the future of this field? Are there some novel therapy that we're expecting? One of the important trials that we kind of, you guys are excited about that are coming in the pipeline.
Yeah, so I can maybe start, but certainly great session here for sure. And so I think exactly following up on Guillermo's comment that we are and the question is, why do we have negative trials? But even when you actually look at the original myocarditis study, you can see that the curves are separated quite significantly on steroids, and then begin to come back together because the original inflammatory treatment, anti-inflammatory treatment, was only for 6 months. And so what happens is that we have a lot of heterogeneity in terms of the population. And, we have patients who actually spontaneously improve, versus patients who obviously, do very poorly. And so you can see that when you give a generic treatment or something like that, you get a heterogeneous response, and therefore it's very difficult to figure out who are the responders versus non-responders. And I think this is the way going forward. So it turns out that there are a lot of excellent anti-inflammatory agents now being developed for various purposes, whether it's in rheumatology or even in oncology. And so the tools are getting better all the time. And it's really, our task to follow up to say, how do we actually define this patient's particular profile? And is this patient, mainly driven by a IL-1 process, IL-6 process, a TNF process, and therefore we can then tailor the treatment because now there are more and more tools, that we can actually target these much more precisely. And so I think this is probably the way that we need to actually go forward. And there are, more trials being designed with this in mind. So I think it's an exciting time, and everybody working together, towards the same goals, I think will be very, very good, especially given, a not as good prognosis that we already saw for these patients.
Yeah, otherwise, I'm not aware of all the trials that are going on. I know, the new agents, like Dr. Liu mentioned, there's a trial going on of anakinra, an IL-1 blocker for acute myocarditis. I think they're still enrolling patients in Italy for the TIMIC-2 trial, which is the prednisone and azathioprine in viral negative patients. I haven't heard much about that in a while. And then there are, I think, ongoing studies of antiviral agents as well. So hopefully we'll have something more to talk about next time we do this. Dr. Torre, Dr. Liu, what do you think if you had to go to Vegas and put your money on where you think the future would be and what the treatment would be? Where do you see this field going?
Yeah, I would put money on tailored therapy, because if you actually see where oncology has gone, right, it's just unbelievable in terms of the way that one can actually target immune system so precisely. Of course, one of these downside is that the immune checkpoint related myocarditis. We certainly know how the immune system can respond. But the thing is actually kind of turn that around, and that is that we figure out what is really driving the process, and therefore specific targeting. And I think this is where tools are becoming available.
Yeah, so I think mechanistic understanding of the actual causative mode of injury is really important. There is no question that viruses can injure myocardial cells and therefore decrease the number of muscle cells, therefore that being one mechanism. And I think when that happens, it may be difficult to reverse that. It's just like when you have a heart attack, you kill a portion of the muscle, that's it. But there is this other component, which is the result of this massive inflammatory response. And clearly cytokines cause reversible LV dysfunction. And I think that can be intervened quite effectively by blocking those cytokines. And whether you block them in a very specific manner with unique, highly specific antibodies or biologicals, that's one approach. I have to remind you in parentheses that our work with anti-TNF therapy failed. But on the other hand, the work by canakinumab in coronary artery disease indicates that there are common pathways of inflammation in the vascular system. Even though may not be approved for that indication, I think from a biological standpoint, you can demonstrate that intervention may decrease a pathway that is detrimental. As you probably know, and Peter, myself, and Barry, and others have been working on a protocol with a non-specific approach that it may be of interest, and we will see. It's already FDA approved in a phase 3 trial for COVID myocarditis, and it's the use of CVD, cannabidiol, non-plant derived. It's a pharmaceutical form that's completely devoid of THC. And the trial was approved by the FDA with the intention of the trial, if positive, may lead to regulatory approval, which is extraordinary, for the indication of COVID myocarditis. So it's a non-specific approach. We'll see. It's of interest. But, the idea whether you have a highly specific versus non-specific, it's something that we've debated for years. I don't know that I would go to Vegas with either. I would work on both, but I don't know that I would invest my entire retirement fund on it. But I would invest on the fact that someday an anti-inflammatory approach for a cardiovascular condition will be beneficial, because we just haven't found which one. But there is no question that from an experimental approach, and Peter has done a lot of work in this field, inflammation contributes to the process of atherosclerosis, cardiac injury following myocardial infarction. It contributes to development of heart failure and the progressive fibrotic condition. So something at some point will give. So we'll continue to work, and will give us an opportunity to be excited about this field for years. Hopefully soon we'll find something.
I think we're just a few minutes left, but there was another case which was fascinating discussion, but I want to bring that point with we talked about this giant cell. I just want to bring for a last, a couple of minutes to talk about this giant cell myocarditis, the importance of diagnosis of giant cell myocarditis, because the treatment can be different and has shown benefit with the multiple immunosuppression rather than like a single immunosuppression. And as we know, this can be very, very patchy, and can be missed. Which we had a case with after 2 of biopsy of myocarditis was negative, and then giant cell was diagnosed of explanted heart after the transplant. So I just want to, the question that comes, if you have a suspicion of giant cell myocarditis and you do the biopsy and come back negative, how do you approach that? Do you go by multiple immunosuppression therapy and then tailor back after that? Or you feel comfortable to just starting treatment with, just steroid for now, and then kind of waiting for more diagnostic, or repeating a biopsy, for example?
Yeah, I mean,
So thanks. So maybe I can start. So for sure, and that's because giant cell, as mentioned earlier, definitely has a different trajectory and also require different regimen in terms of immunosuppression in order to change the natural history, and the natural history may also include cardiac transplantation, exactly as your case has indicated. And so, if the patient, for example, has a fairly, fairly dire state, especially there's also arrhythmias to add on top, and so then one probably should actually repeat the biopsy, particularly if the suspicion is very high, just to make sure that we didn't miss, the patchy spot. And nowadays, there are strategies, for example, using imaging guided or electrical, electrophysiologically guided type of biopsy to improve the yield, and sometimes even consider both RV and LV biopsies, just to make sure we don't miss it. But there's no question that the case you described that happens. We had cases like that as well. And keep in mind that giant myocarditis is very persistent. So even though we have a good regimen keeping the patient quiescent, it may still come back. Many years later. So one can never be kind of falling off on the vigilance of this condition.
Well, that's great. I think that wraps up the hour. This has been a great session. I think we can go for another hour or two if we wanted to. We really want to thank our guests, Dr. Peter Liu and Dr. Guillermo Torre, who's kind of a guest, kind of not a guest, and Dr. Yousefzai for putting this together. So.
Thank you so much. We appreciate you joining us.
Thank you.
All right. We'll see you guys on the next Heart Failure Hour. Thank you.
Thank you.
Thank you. We'll see you later, Peter.